Good morning. I'm Eileen Jones, and 10 years ago, can you hear me? 10 years ago, I did start Miles for Migraine. Thank you. Partly because when I went to visit Senator Dianne Feinstein's office and spoke to her legislative aide, she said, you people don't know, but funding for NIH is flat. It's been flat for many years. And we're not going to take money away from, we're not going to, thank you, take money away from any other group to give to you people. And I said, well, we're not asking that. We just would like to get in line. Because I was shocked to find out that less than 1/10 of 1% of the NIH budget is given to migraine research. It's appalling. So when I said to this legislative aide, well, how can we do that? We just like to get in line and make our needs known. She said, well, you're going to have to go figure that out for yourself. I can't help you. And so that was September of '07. And I thought and thought about it, and I was in a very bad period from 2003 to 2007 where I wasn't totally homebound, but I was operating definitely at half speed. And I thought, what can I do? I'm just this one person who's just schlepping along best she can. And I thought, well, I'll just join a race. Every other disease seems to have a race, and I'll help those people. And when I found out that there was no race, no event for migraine, I decided to start one. And my husband and I used our savings to get this off the ground. It meant that much to me. And a lot of times I felt like this would never happen, that it felt like the patient had coded a lot of times and we were out of money a lot of times. But we're here, many thanks to Shirley Kessel and Dr. Bill Young, who have really brought in the money to this organization because it needs money. As you know, angel investors are what people look for. So with the money primarily from pharmaceutical companies, we have been able to do things, for example, like this today. And I'm very happy that it's our 10th anniversary. I'm also so happy that each one of you came. I know I probably can't talk to you individually, but believe me, I understand your pain, and hopefully there'll be an end to it before we're too old. And I would like to introduce Raj Trailer, and he is our major sponsor. He represents Amgen. Raj?
Thank you very much, Eileen. Good morning. I get the distinct pleasure of introducing our speaker this morning, Dr. Morris Levin, the author of Understanding Your Migraines. First of all, Amgen is very proud to be a sponsor here today. Thank you very much, Shirley, Miles for Migraine, for having us. We love these events. It's very important to us as a company, so thank you very much for having us. Dr. Levin serves as Chief of the Division of Headache Medicine and Director of Headache Center here at UCSF. He specializes in the management of all forms of facial pain and headache, including migraine, cluster headache, cervical genetic headache, and post-traumatic headaches. His research area interests include cervical genetic headache, post-concussive headache, diagnosis in headache, and medical education neurology. Dr. Levin earned an undergraduate degree at Stanford University and his medical degree at Chicago Medical School. Subsequently, he completed a residency in neurology at the Albert Einstein College of Medicine in New York, followed by a subspecialty training at the Montefiore Hospital Headache Unit and Michigan Head and Pain Neurological Institute. He is board certified in neurology and pain medicine by the American Board of Psychiatric and Neurology. He is also certified in pain medicine by the American Board of Pain Medicine and holds board certification in headache medicine from the United Council of Neurological Subspecialties. So without further ado, Dr. Morris Levin.
Thanks very much for that introduction. I sound pretty good. I can hardly wait to hear what I'm going to say today. Well, thanks very much to Shirley and the rest of the Miles for Migraine group. A lot of hard work went into putting this together. You'd be surprised. Thanks also to the sponsors. I really do appreciate it. But especially thanks to all of you who came. If I'm not mistaken, some of you are here not feeling so good, and would have rather stayed home and would have rather relaxed. But it's so important to have a critical mass like you're creating. I can't tell you, so thank you very much. Let's see. How's the sound projecting in the back? Front good, all good, okay. How are the lights in the room? Are they bothering anybody? Do we need to dim them? Can we do that? Any way to do that? Great. So this is going to be a lecture, but if you're anything like me, lectures can get a little dull. May not be the best way to interact with people. I really don't mind at all if you interrupt. I know that differs between personalities, but if you have the urge, please shout something out. Stop me. If you think I'm going off base, I really don't mind. I want you to do that. Or you have a question. When I'm finished with my little lecture here, Shirley is gonna come up and we're gonna have a little bit of a to and fro with questions that she and Shirley, and I guess maybe I contributed some questions to, just sort of imagining what people might like to talk about. But at the end of the day, there'll be a panel of a lot of us sitting up here for you to ask questions. And of course, there'll be other times I'll be sitting at the table. Please feel free to ask me or anybody else any question that comes up. What I wanted to do was just give you an overview of how I think of migraine. Those of you who are my patients, you've heard it all before, sorry. You'll hear some of this again. And hope that I'll be covering some of the key areas that you're interested in. I'll try and make it brief, but again, those of you who know me know I can go on and on. Please, again, that's another reason to shout out to stop me. All right, so let's see if I know how to advance this. That didn't work. That worked. The little wheel, or should I use the arrow? I should use the arrows. Okay, great. So here's what I thought I'd try and cover: how migraine is diagnosed, how it affects you. You probably know a lot of this, but I'm going to cover some areas that might be new to some of you. The causes of migraine, I'll be brushing over this because there's a lot we know, but as you probably realize, there's a lot we don't know about migraine. How to manage migraines on your own, medical management that we have, and then a little bit about advanced treatments. Dr. Michael later is going to talk about some of the newer treatments, so I'll avoid that for now. I know you're concerned about that. So what we headache specialists use as kind of our guide, our map to diagnosing headache, is this document here, the International Classification of Headache Disorders, just published as the 3rd edition. And this is what everybody in the world supposedly is going to use to diagnose headaches, to categorize headaches. And a lot of my new patients come to me with one main question in mind: what kind of headache is this? Is this a serious headache? Is it migraine? Is it some other kind of headache? This is what we use. And the first part of this classification is so-called primary headaches: migraine, tension-type headache, cluster headache, and things like cluster headache, and a category that's some other various headaches. We call them other headaches. And then the second part of this classification is the so-called secondary headaches. I know you've heard that term, secondary headaches, meaning the headache is due to some other process, whether it's in the head or neck or other parts of the body causing headache. It's what a lot of my patients, when I first meet them, are most concerned with. Could it be one of these other things? Some of the dreaded things. That's in the secondary section. So what is migraine? What makes it migraine? Why do we say you've got migraine as opposed to some of these other headache types? I'm not going to belabor the whole classification definition, but look at C and 1 and 2. The unilateral quality, so one side of the head, and pulsating quality. That helps us a lot, but guess what? If you don't have either of those two things, you could still easily have migraine. In fact, if I had to boil down my thoughts for today, it's that most everybody with recurring headaches has migraine, just about everybody. But those things help us make the diagnosis. If I had to pick one symptom that makes it migraine and not other things, it'd probably be nausea. And that word doesn't mean the same thing to everybody. It may not mean that horrible nausea that leads to vomiting, but just that queasy, crummy feeling. The French have a word for it, malaise, right? That seems to be a very common accompaniment to migraine. And then sensitivity to light and sound. You know, how many of you didn't like the lights when I just asked that question? Very, very common quality to migraine. What about migraine with aura? What is that? Well, we conceive of migraine with aura as a kind of migraine, similar in a lot of ways to migraine without aura, but for those of you who have it, like I do, it does feel quite a lot different. Who in the room have had auras? Strange, right? Spectacular sometimes, visual, and I'll show you some examples of some of the auras, but here they are. I've listed all the common auras: visual, sensation changes, speech and language changes, cognition, which is, of course, highly linked to speech and language, weakness, so motoric problems, motor problems, brainstem, which refers to a lot of things that can happen coming from this part of the brain that's very complex, the brainstem, and retinal, visual changes just from one eye. Very common visual aura, these jagged lines inside of which there's blurriness. It's a very common kind of complex visual aura. A lot of people describe a kind of tunnel vision. In the middle of the tunnel they can see, but outside it's blurry and disabling, because you really need to have a good visual field to do things, of course. It's the best picture I could come up with to illustrate vertigo, the feeling that you're moving or the world is moving around you. This is a famous old depiction of something that has been seen in a lot of migraine sufferers, and that is distal part of the hand, fingertips are going numb or tingly, and then it starts to ascend up the arm. Why is this such a big deal? Because there's almost nothing else that causes that other than migraine aura. And then accompanying that comes the visual aura too, in this patient here. Chronic migraine, you've heard about it, many of you have it. Very demoralizing illness that seems to progress from intermittent migraine, episodic migraine. What's the definition? More than 15 days a month of headaches, the majority of which have a lot of migraine features, whether it's true migraine or whether it responds to migraine treatment or something like that. Lots of headaches, the majority of which have some migraine features. That's what chronic migraine is. When you use that, of course, I'm not using the actual words of the definition, but if you follow what I just said, you probably realize there are a lot of people who have chronic migraine. And there are other headaches, of course, cluster headache and tension headache. Rather than go through the international classification criteria, I thought I'd just give you my gut reaction to headaches and how I categorize them. So here's migraine. Unilateral and throbbing, that helps, doesn't have to be there. There's a female predominance, as you know. Nausea seems to be a very distinct feature, and maybe aura. So what's tension headache? Tension type headache is everything that migraine isn't. In other words, no auras, no nausea, not as severe, although they can be annoying. Again, the lack of nausea. Cluster headache. Cluster headache, particularly severe headaches, male predominance as opposed to migraine. They really are unilateral. They stay on one side. In fact, they stay right around the eye for most patients. They come in cycles, during which, for several weeks, a person has these terrible headaches, 1 or 2 or 3 a day, and that's why it's called cluster headache. They cluster in these cycles, terrible headaches. But the hallmark of cluster headache, as opposed to migraine, is how brief they are. They're an hour. I mean, how long is a migraine going to last? Never an hour, right? You'd be very lucky to have an hour-long migraine. When do we look further? When do we ask ourselves, okay, this seems like migraine, it sort of fits, but should we look further? When do we do that? That's a picture of an MRI machine, one of the things we do when we want to look further. A new severe headache. Well, migraines have to start sometime, so maybe that's just migraine. It could be, but new headache. Or I've learned in my career, when a patient tells me, yes, I've had headaches for many years, but something changed. Something's new. Those words mean something to me. I've learned to take those words very seriously. So something new, some change. Neurological symptoms, and you know what I mean. Weakness, sensory loss, visual loss, cognitive changes, things that maybe, if they're transient, if they're temporary, that's kind of typical of an aura. But if they start and they just persist, that's a red flag, and we look further. Or what if the headaches are happening in the presence of a systemic illness, whether it's a collagen vascular disease like lupus or cancer or kidney disease, etc. That bears looking into. So systemic illness, and that's really if I could get that concept across to young physicians that train with me, I think we'd be making a huge leap. Those are the times to look further. I thought I'd share with you just some other common headaches that you'll hear about. New daily persistent headache. Very, again, demoralizing illness. It's headaches that resemble migraine in a lot of cases, although often without a lot of migraine features, that start on a particular day, and people remember the day and persist ever since then. Every day, new daily persistent headache. Why do we use such a simple-minded title? Because we really don't know what causes them. Maybe it's an infection that happens, and this is left in the wake of the infection. We just don't know. They're very difficult to treat, but we use treatments in the migraine category, and we've been reasonably successful. Medication overuse headache. You all know this one, also known as analgesic rebound, a term that I'm using less and less. And tell me if you agree with me. Analgesic rebound. That word to me sounds like it's when the medication wears off, there's a rebound pain. That's not necessarily what we're seeing. What we're seeing is just an intensification of the underlying headache because of taking just too many painkillers. And it's unfair, right? It's totally unfair. This is the medicine that is working for your headaches. And Mother Nature's kind of mean. It works, but then if you take too much, you get worse. Very unfair. Life's not fair. I know that's news to everybody. Medication overuse headache. Luckily, we have some options there for treatment, and I'll share those with you in a minute. Post-traumatic headache. This, if you don't know it already, is an epidemic. There is so much in the way of traumatic brain injury that is maybe better diagnosed now, but I think it's actually happening more and more. There are more head injuries than ever. Probably 2 million head injuries in the country per year. About half of them get to the ER. Lots and lots of head injuries. And the most common sequelae, the most common residual problem after a head injury is post-traumatic headaches. We don't know why they happen. A lot of times they act like migraines, and we treat them like migraines. But it's very common, and many of my patients, this is the main problem they come to see me for. Cervicogenic headache. This is the fancy medical word for a headache that's really due to a neck problem. I believe in this. Some specialists don't. They think that it's a minor issue. I think it's quite common, especially in elderly folks. In other words, neck problems, whether it's disc problems or arthritic changes or deformities of the neck or neck injuries leading to head pain. And the reason that it happens is because the way we're wired, the way pain is managed in the head and neck and face is such that a pain generator in the neck, whether it's any of those things I mentioned, can actually be perceived as head pain. I've seen patients who've had a disc problem right in the middle of their cervical spine who have pain in their eye. And vice versa, I've seen people who have sinus problems who have neck pain. Many migraine sufferers have a great deal of neck pain. It's because of this wiring, and so I think it behooves us, all of us specialists, to keep looking. Look for neck problems, look for all of the problems, all the things that I summarized in that slide that I showed you about the classification. Let's do a couple of words on medication overuse headache. One of my patients actually brought me that picture many years ago and said, "This is what you doctors make me feel like." I took it to heart, Yes, we do throw a lot of pills around, and we've got to watch it. I was just talking before the program started today, I was talking to somebody about how she was frustrated at how many pills her loved one had to be taking and go through, and I share that concern. I don't like the idea, but if they work, great. If they don't, we should get rid of them. Anyway, acute pills, acute meds for headache can worsen the problem. We're still wondering what this is all about. It's not withdrawal. It's not that you've taken the pill and you go through withdrawal and then get the headache back. That's not what it is. It's some reorientation, rewiring of the brain after being on this type of medication. There's a tendency with this whole concept to almost blame the victim, and I think you know what I mean. It's like many of my patients will say to me, "I'm not taking these meds for fun. I'm taking them so I can function." I completely get that. On the other hand, we're not going to make progress until we get that problem solved, the medication overuse problem. So I thought I'd give you just a look into what we think when we see our patients with headaches. Does that make sense? Would that help? I'll go quickly because I know I'm not teaching medical school here. What do? When we hear people talk about their headaches, we ask all these questions. When did the headaches start? Where are they? And so on. It doesn't take, when you've been doing this as long as I have, it doesn't take very long for me to focus in on what the key problem is. But this is a good analytical way to get at it. And if we learn enough about all of these questions, I think we can pretty much make the diagnosis. In addition to taking a history and listening to the answers to all these questions, we do an exam. Oh, I meant to talk about this headache log. How many of you keep headache logs? How many of you love your headache log? 0. It's always the same. Why is that? Yeah, no, I know why. Because, enough's enough. You get a lot of headaches. Why are you having to write them down? I mean, the main reason is to see if whatever intervention we're making, whatever medication or treatment, is it working? We only know because we look at the headache log. Human memory being what it is, we don't remember the last month. We remember the last few days about our lives. So these help. They also help to, give us clues about what may have triggered the headaches, what activities are good and bad, what times of the month are good and bad. Knowledge is power, and these logs do help us. They're all different kinds of logs. I have no particular preference, as long as I can kind of decipher it and read it. I know a lot of my colleagues in the headache world have their headache log. You have to use it, and if you don't use it, you're in trouble. I don't care. As long as I can kind of get my mind around it, I can interpret it, whatever's good for you. There are lots of programs. I know a lot of you, how many of you are using these online programs to track headaches? They're good. I mean, it's all personal preference. This one, I guess I kind of like this. In principle, I'd never use it, frankly, I'll admit, but because it's too much. But I like it because it has a lot of information, including weather changes and so on. So I kind of like it. Here's a headache log of a very typical chronic migraine patient, actually daily migraine patient. I mean, it's scary to look at. I know sometimes when you look at your own headache logs, it's scary to look at them. This person, the reason I like this one is you start to see a little sunlight at the end. I don't know if I have a good pointer here, but sort of towards the end of this isn't really working, but there's some headache-free days. This happens, I promise you, even though it hasn't maybe happened for some of you, it does happen, and this is the way we see what's happening. What do we do when we examine patients with headaches? As you can imagine, good general exam. We look at the head and neck very carefully. I've learned over the years that that's a very important part of the examination to do. Look at the eyes, neck especially, face, facial structures, etc. And we do a neurological exam to look at all of the things our brains and brain stems do for us. And I won't belabor it, but it's an involved exam. Most of us can do it in about 5 or 10 minutes. Very important to make sure, again, that we're not missing one of those scarier causes of headaches. What about testing? It's one of my favorite cartoons. Doctor says, well, Bob, it looks like a paper cut, but just to be sure, let's do lots of tests. Again, I know this is what my patients think of us. I'm sorry if you feel like we're over-testing. Sometimes we do. Sometimes we look back on the testing and think, what, was that really going to change anything? Most of the time, there are good reasons. Even if it's a 0.1% chance that we might be missing something, we feel like we owe it to you to make sure we're not missing anything. So what are they? Blood tests. Blood tests are easy, and surprisingly, they can tell us a lot. I can't tell you how often simple blood test makes the diagnosis for me. I pick up a case of hypothyroidism, for example, about once a month. I'm not kidding. Diabetes, kidney disease, all sorts of things can be easily identified with blood tests. When to do imaging of the head and the neck, again, looking for those red flags, new symptoms, new changes, in the setting of medical illness. That's when we do some of these other tests. Lumbar puncture, I always use that little phrase or these 4 lines because I do a lot of teaching of med students and residents, and I want them to understand the only time to do a lumbar puncture is in these situations. When you think there's been a hemorrhage, when there's high or low pressure in the head, that's a possibility, or when there's an infection like meningitis. It's the only time to do LPs. When do we look at blood vessels of the brain? It's a more complicated issue. Usually we don't need to in migraine cases, in headache cases, but sometimes we will. And what they look like is very much like a regular MRI or CAT scan, but we do some different modifications during the testing. The picture on the left, of course, is an MRI scan of the neck. I get a lot of information from these. On the other hand, I force myself not to order too many because the only really good reason to order imaging of the neck is if we think it's going to change things. If we think we're going to send a patient for some procedure or treatment focused on that presumed neck problem. Next picture, middle picture, is a brain MRI scan. And then the lower picture, the right-sided picture, is a picture of veins of the head, sometimes very important to have a look at. So we have lots of these options, and luckily at UCSF we have the help of some unbelievable neuroradiologists. These are experts in knowing not just which test to do, but which tests not to do. And I think you know what I mean. We could easily order 10 imaging tests, but they help guide us into areas where we just need to go and areas we can avoid. So despite all of this, despite everything I've said about, headaches and all the different varieties, guess what? Severe recurring headaches usually are migraine. How's my time going, Shirley? 5 minutes? I could be. Let's go really quickly through mechanisms of migraine. I don't mean to. This is something I do want to linger on. The effects of migraine. I don't need to tell most of you about this, but suffice it to say, migraine is not just headache. I know that's an obvious statement. Guess what? Most people who don't have migraines or don't know people with migraines do not know that. They do not know that. You heard of what Eileen was saying about some of the symptoms she was having, what Shirley was saying. This is the rule. It's not just headaches. So there are all sorts of things. And of course, all of these symptoms, if you want to call them that, affect us dramatically. At work, in social life, at school. And I won't say much more about that, but I just wanted to sort of honor that a little bit. Here's some numbers. I don't know if you like statistics, but they're kind of staggering. 14% of the world's population has migraine, and about 1 to 2% of the world's population have chronic migraine. I mean, we're talking about millions and millions of people. Third most common illness in the world, seventh most disabling. 1 billion people in the world have migraine. That's pretty shocking. So in terms of the mechanism, I think I better skip through this pretty quickly, and we can talk later if we need to, but it's still very murky and still very mysterious, but we think there is an electrical phenomenon that happens in the surface of the brain, around the surface of the brain, called cortical spreading depression, that starts the process going. This neurophysiologist Aristide Liao was the one who discovered it. Blood vessels are then inflamed, and we think due to this spreading depression, they are inflamed, and the nerves around them become activated. And there's a part of the brain where these nerves stem from, where the trigeminal and other nerves stem from, that becomes activated, and the whole process becomes this reverberating cycle, and that's why migraines last so long. So I'm going to skip through that slide. Let's spend the last couple minutes on managing migraines. This is what you're all wondering about, probably many, many hours of your life, how to manage migraines. I wanted to start with this non-pharmaceutical, non-medicinal area because I think it's been underplayed, underused dramatically, right? Some of you are nodding with me. Of course, avoiding triggers, yes, obviously, and we look for triggers. Can't live in a glass bubble. We can't make those triggers go away, but we try to avoid them. Exercise, turns out moderate exercise 3 times a week has been shown to help prevent migraine. Some pretty good data. Regulating sleep, and by that I mean try to make that sleep system very consistent. One of the things that some of you who know me, or my patients know, that one of the things I harp on is that migraine people like me, like you, have to have regularity, have to have rhythm in their life. If they don't, it's much harder to get control. So sleep regulation is one of those. Try and wake up at the same time every day. All of the relaxation techniques, this is what I'm calling them, the relaxation techniques, I think are very similar. From yoga to biofeedback to meditation, hypnotherapy, I think they all do something that we can't quite categorize yet. They do something that helps migraine pretty dramatically if you do them regularly. So I'm a very big supporter of those. Massage, probably the oldest treatment for migraine in the world, thousands of years old, really helps, but it has to be done regularly. And guess what? No insurance company will pay for it. Unless you have, please tell me if I'm wrong, if you found an insurance company, we'll all sign up. Physical therapy. So medications, you know about these. I'll go through these pretty quickly just to sort of set the stage for what we'll talk about in later parts of the program. Triptans have really made a big difference in migraine. Do they always work? Unfortunately, no, but they're very good, and there are a lot of choices. Ergots, another category, have not been used as much lately because they're more risky, although dihydroergotamine, a lot of you know about it, very effective, but it really only works in the intravenous form or intramuscular shots. We call them specific because those things really just work for migraine, but these other nonspecific meds, do they work for migraine? They do, but not great. NSAIDs, opioids, the so-called dopamine agonists, these are the anti-nauseant types of painkillers. They, like compazine, Reglan, they do help, but they're hard to use. Here are all the triptans. I don't have a favorite, although some of the logos are kind of, I like the sun and the moon and emerge. I think that's kind of pretty. And these are all the potential side effects to all of our brilliant interventions, right? Not so brilliant because they all tend to cause problems. I love this cartoon, one of my favorite cartoons, what is this is BC, right? Yeah. Never take a pill that has more side effects than you have symptoms. Well, it's funny and sad, right? I think you're all agreeing with me. I'm going to skip through this because I wanted to get to this slide. So prevention. I have a friend who's a very successful businessman, and he said, you know, you guys don't understand business principles. We have two ways of solving problems: crisis intervention, which we hate, and prevention, which we love. Well, we do the same thing, actually. We really don't like to have you end up in the ER or have to take heavy-duty acute meds. We'd like to prevent. These are the preventives. The ABC are sort of the standard anticonvulsants, that's anti-seizure medicines like Topamax, topiramate, beta blockers like propranolol, the cyclic antidepressants like amitriptyline and nortriptyline. They really are the standards, and they help a lot of people. Unfortunately, at headache centers like ours at UCSF and other headache centers, we see a lot of patients who failed with these. We still don't know why that is, but we have others. I've listed some of these on the rest of the slide. What about chronic migraine? Do we use the same things as we use for other migraine conditions? Yeah, we do. We go a little further afield. We have Botox. We have other preventives that we use that are from other fields. We do nerve blocks. There are stimulation devices. You'll hear more about that in a little bit. So just a picture of where we do the Botox injections. How many of you have ever experienced? I shouldn't ask. You don't have to raise your hand. I don't mean to make you share details. Anyway, this is where we put the injections. There she is getting one. Nerve blocks. I've been doing this for many, many years. I still don't really know what the mechanism is for why nerve blocks help chronic migraine, but they do. Not for everybody, but they really can help. We have some stimulation devices that have been helpful for selected patients. I'd say I see maybe best results with the magnetic stim, but other people do get results from the one on the left. That's a Cephally device, and the vagal nerve stimulator just became approved. That's the gammaCore that she's using in the middle. These are other stimulation devices. I think you'll hear more about those later. I wanted to spend 1 minute or half a minute on herbal and supplement therapies. I know you've all been interested in these because they are attractive. The side effects are lower. You don't need a doctor's prescription, and some of them really do help. There's pretty good evidence for B2 and magnesium. Feverfew, there's some evidence for, but it's got a salicylate in it. It's from the leaves of the feverfew plant, which you see here. That was a plant that was growing in my backyard a long time ago. And so it can cause problems, salicylates like aspirin. Butterbur we used to use a lot, but turned out to be toxic to the liver, so it's not such a good idea anymore. And there's some other ideas, CoQ10, melatonin, boswellia. Ginger doesn't really help headaches, but it's a very good, what does it get, do you guys know? Nausea. It's pretty good, and this is candied ginger, it really helps. This is a picture of the Boswellia tree. And I've learned a lot about this lately. It grows in arid environments, and its resin, which I guess is the sap. Anybody know trees here? Yeah, okay, sap of the tree. Sort of congeals and becomes hard, and you grind it up, and that's what Boswellia extract is. And it's been used for literally thousands of years. And the other name for it is Indian frankincense. So that was in the Bible, frankincense, and was given as gifts. And it really does have some evidence, not strong, but has some evidence as a pain preventive. I'm going to skip through the approach to medication overuse headache because I don't think we have time, but suffice it to say, we do have options other than just saying you've got to stop taking those medications. A lot of you know about those options. It can be fairly convoluted, but we try and get people off the medications, try and replace them with others. We use something called a bridge therapy, which can be prednisone or other things. Let me just finish by showing you a picture of a game that I had. My sister and I used to play when we were little. This is our actual one, Headache, called Headache. It's like Parcheesi. It's this game that play on a board, and the little markers go around the board. I always thought it was strange it was called Headache. Well, they reinvented the game a few years later, and they called it Trouble. Same game, same exact game, Trouble. Finally, same game again, repackaged in the 1990s, Frustration. Talk about stigma, right? I think this is unfair, this whole thing. And here's the way I think of headache treatment. Here's what we feel like sometimes. I believe if we put our minds to it, and I'm talking about physicians, nurses, patients, families as a team, we can turn this picture into that. And it's not easy sometimes. It's frustrating. It's demoralizing. But I'm very hopeful. There are very few people I've met with headache problems that haven't been able to get better. So good luck. Thanks again for coming. I'd love to chat with you and meet you later in the day. Thanks again.
Thank you, Mo. We're going to have a few minutes just to go over some pre-selected questions. And we're just going to sit here.
This is an experiment,
so
so tell us how it goes.
You'll have a chance to ask our panel at the end of the day. If you have a question, please write it down so you don't forget it, because we do want to answer your questions. We'll just start off with, especially since we started out as a race. What do you think is the importance of exercise in dealing with migraine?
Exercise is kind of fascinating, right? How's the sound, by the way? Is this microphone on? Good. Kind of a fascinating area because I bet a lot of you with migraine know that if you exercise too much, it'll bring on a migraine, right? That's happened to me many times, in fact. And so what is this all about? It turns out the evidence is best for moderate exercise several times a week. So you can probably go too far, and then if you tend on the other side to become sort of a couch potato, also bad. So all I can speak to is the limited evidence, which is that moderate exercise about 3 times a week prevents migraine in a lot of people. So we'd like to know more. I actually tried to run a study when I was at Dartmouth, and we even got funding for people to get club memberships and all sorts of things. And I had a list of exercises that you had to do, and it was funny. You had to sign up and then be randomly assigned to exercise or not exercise. Nobody signed up, and I thought, oh, this is because they didn't want to be in the non-exercise group. Just the opposite. They didn't want to be in the group that had to. So, can you explain that? I'll ask you, can you explain that?
I can't explain. I wouldn't even attempt to. Many of us have been employed and lost our jobs because of migraine. What can you tell people is the best way to approach an employer about a problem with chronic migraine interfering with your ability to do your job?
It's such a big problem. And it's not just employers, it's teachers at schools. I mean, in a lot of my patients, migraine peaked in high school and college time. Terrible time because, as all those of you who've been in college and even high school know, that professor thinks that all you have in your life is that course, and they're not going to be very responsive to somebody saying, "Oh, I can't. I didn't feel good." I mean, the trick, as you know, Eileen, is to find somebody who's sort of simpatico, who's had headaches themselves maybe, or has a family member who has headaches, which is not that uncommon. Most people do, and sort of enlist their sympathy. There is the Disabilities Act, and that does protect students and employees, so that can be enlisted. All it sometimes takes from me is just a note saying, this person is a patient of mine, has intermittent headaches which cannot be predicted, and will disable her or him from work or from school. That's sometimes all it takes. But I'm being glib because this is not easy. And maybe this is something we can brainstorm about later. Maybe we can learn from each other. Maybe you've had some good experiences, some bad ones. Let's put our heads together.
Thank you, Mo. I know that one of the former members of our board was so debilitated with migraine that she had to leave her job. And she hired an attorney. She had to hire an attorney and spent quite some time before she was able to secure Social Security disability benefits. And it's not much, but as a single woman, she desperately needs it. What information would you like your patients to bring to you besides the headache diary? When they come and see you, what is most helpful for a constructive patient visit?
Great question. And we were going to put this on our website, right, Amy? Hopefully it's going to be, yeah. So it's a good thing to have on our website, right? So that you'd know what to bring. I think one important thing would be a list of treatments, medications you've tried before. Diary, very important. I think it would be great if you've had testing to get test results, so we don't have to repeat something. I hate it when I have to repeat, say, an MRI scan and somebody's had one, but we just can't find the results. Even if it's a number of years ago. What else? Anything else anybody can think of? Amy, what do I forget?
I think I would really stress the first part about bringing the preventives, because just like how you don't want to repeat scans, you don't want to reinvent the wheel and try something you've already tried. But if you don't come with the max dose you tried,
Yeah, the max dose, how long you were on it, right. Rebecca, anything else? Am I forgetting it?
No, that's right. Those are
Probably
good
the most
medications.
Yeah. No, it's good. And I mean, don't worry if you don't come. You can come with nothing. Believe it or not. New patients, we see new patients sometimes with nothing. It's okay. Sometimes it's fine, because one thing I don't pay a lot of attention to is, and I'll deny this if you ask later, but a brilliant note from some other practitioner. It could be great, but I'm stubborn. I want to think it through in my own way. So you don't have to bring those.
Thank you, Mo. What do you tell someone who has been through many doctors, many workups, many tests, and been on literally dozens of medications, treatments, and feel that they've come to the end of the road and they're losing hope? What do you do for that patient?
I think hope is the key word. I actually did something when I was younger that I don't do anymore. I used to say to patients who I would see, I'd seen for many times, and they were not getting anywhere, and they were really getting just depressed about the whole thing. And I thought to myself, why am I making them come back to see me? I'm not offering anything. I'm not getting anywhere. And I used to think to myself, I'll just say, let's cut the cord. I haven't helped you. I'll find you somebody else. And I would say that to people. I'd say, I'm not really helping you. I don't want to waste your time. And invariably, they'd say, no, I want to keep coming because I think, maybe someday we'll find some. And it dawned on me, that phenomenon, and then another thing happened that I don't have time to go into, dawned on me that that's exactly the wrong thing to say, because I didn't really mean it. I want to keep trying. I want to, no matter how many things you've tried, how many places you've been. I have the urge to keep trying because maybe I'm just a natural optimist. I always think there's hope. I think there's hopefulness to be found. The field is changing, despite what you heard from Shirley and what you'll hear from others about the lack of funding in headache. There are new developments. I just say, we're going to fight this battle together. We're going to, even if we get incremental improvement, we're going to keep fighting the battle together. And it's not a great answer to the question, but it's what I do.
Thank you very much, Dr. Levin, for your informative presentation.
My pleasure. Thank you.
Yeah, we're just going to stop the questions a few minutes short because obviously we're running behind schedule, but that's okay because we are going to just take a little time off of lunch. And, but I just want to, first of all, thank you again, Dr. Levin. That was fabulous. And I wanted to make a few announcements before we're going to take a pause and do a little stretch in just a moment. But I want to let you know that Dr. Levin's books are for sale. If you want to stop by, he'll be doing a book signing at lunch. And there is a quiet room that if anybody needs to take a break, if you walk out the front and make a left, go down the hall, you'll see a little sign with a lotus, and that's actually a meditation room. And so if you feel like you need to take a break, please go down there. And last, I want to mention right now, the schedules were already being shipped from Philadelphia to San Francisco when we found out that Dr. Rob Cowan would not be able to join us today. So if you could make the change, or you don't have to, our presenter will actually be Dr. Rebecca Michael, who will present us in the afternoon. So with that said, I'd like to call up, is Annika, are you doing a brief pause and stretch with us? Somebody want to? We're going to just take a little break because this is a day about self-care also. So we're going to spend a lot of time taking care of ourselves. Are you good to do that with us?
Sure.
Okay.
Do you want to do it together, Shirley, or did you have something in particular in mind? Or I think just getting up and standing up and really doing a nice stretch. Sorry, I was getting some tea while we were having a little break. Oh, okay. This actually probably should go down if I'm going to do some physical movements.
Yeah, go ahead.
But if everyone just stands up and just take a nice deep breath in and let it out and kind of relax your shoulders a little bit. And then lifting your arms up in the air and stretching up and then out to the sides. Good. And then if you're okay to twist a little bit back and forth, that feels really good. And we can do a little shoulder rolls too. It's crazy. Back and forth. And did we want to do any other, Okay, good.
Yeah, I like this.
Well, Shirley, you're trained as a yoga instructor.
Well, I haven't
correct?
taught yoga in a couple of years, so. But
And then a little neck roll is always good if your neck allows for it, of course. And then I like to shake things out before I sit back down. Yeah, so I like that. Just to loosen up. All right, is that a
that's
good little
How's
break?
everybody feel? Is that good? You need more? We're going to have more later in the afternoon. I'm going to call Eileen up again to introduce Dr. Becker, our next speaker. Eileen, are you still here? Oh, there you are. Okay, good. Also, the bathrooms are out to the left and then a left if you need the restroom.